All right. Hello, everyone. Good morning, good afternoon, good evening, wherever you are. Welcome to our kickoff to the 2023 Grand Round session. My name is Cecilia Sorensen, and I'm pleased to welcome you to today's session, Climate Smart Pharmacy, a prescription for a healthy planet. This is brought to you by Healthcare Without Harm and the Global Consortium on Climate and Health Education. So as many of you know, we held 5 Grand Round sessions in 2022, which explored strategies to reduce healthcare emissions and featured the leadership of clinicians and researchers. We are delighted to launch a fresh series in 2023. If you missed any of the previous sessions, you can find the session summaries and the recordings posted on the Grand Rounds series webpage, and the link is in the chat for those. This series is loosely framed around the global roadmap for healthcare decarbonization, which was released by Healthcare Without Harm and ARUP in 2021 as a first of its kind guide for the healthcare sector. As many of you know, our healthcare sector has a large carbon footprint responsible for 4.4% of net global emissions. Under a business as usual scenario, healthcare emissions are expected to more than triple by 2050. So this roadmap is a navigational tool that outlines 7 high-impact actions that will help the healthcare sector achieve net zero emissions by 2050 and align our industry with the goals of the Paris Agreement. So in today's session, we're going to hear about the climate impact of pharmaceuticals, along with opportunities for health professionals to promote climate smart pharmacy practice through education, advocacy, and bedside care. We would like to draw your attention to key action number 5 in the roadmap: incentivize and produce low carbon pharmaceuticals. Before we jump in, I want to acknowledge the planning committee for this series, which includes an interdisciplinary group of colleagues from Healthcare Without Harm, the Global Consortium on Climate and Health Education, and NYU Langone Health. So today you'll be hearing 3 short presentations, followed by a moderated discussion and Q&A. If you have questions you'd like to pose to our speakers, please enter them using the Q&A function, which is found at the bottom of your screen. If you have a question for a particular speaker, please indicate that. We also encourage you to chat amongst yourselves using the chat function. This is separate from the Q&A, but also found at the bottom of the screen. So today we have 3 incredible speakers who are really leading the charge in this space. Minna E is a pharmacist in Northeast England who serves as the Vice Chair of Sustainability at the Guild of Healthcare Pharmacists and is the co-founder of Pharmacy Declares. We'll also hear from Alex Rabin, who is a clinical associate professor of pulmonology and critical care medicine at University of Michigan. Dr. Rabin works to understand the impact of respiratory exposures on patients and minimize the environmental impact of healthcare delivery. And we'll hear from Dr. Haley Blackburn, who is an associate professor of pharmacy practice at University of Montana and a clinical pharmacist who leads didactic coursework, experimental learning opportunities, and research efforts exploring the role of pharmacists in the development of environmentally sustainable, climate-resilient healthcare systems and communities. So with great pleasure, I will turn it over to Minna.
Hello, everyone. Can everyone hear me okay?
Yes.
Hands up. Lovely, thank you. My name's Mina. Thank you, Shanda, CC, and colleagues from Healthcare Without Harm and GCC for inviting me here today. I'm gonna just see if the slide moves. Lovely. I've put some of my current job roles and titles on the slide, but I want you to see that I'm no climate change or sustainability expert. I'm just a healthcare professional like most of you who cares about the planet, focusing on what we can collectively do to create a better future for all. After this talk, I want you to all feel empowered, no matter your role, to be able to make changes in your workplaces if you want to, and within your personal lives. So I've been told I have a very well-informed audience today regarding anthropogenic climate change, and I won't go over why we're talking about it in healthcare today. So this is an extract from the UK's Greener NHS Net Zero report, where healthcare activities in the UK comprise of 4% of the country's total carbon emissions. As you can see, I've highlighted medicines, inhalers, and anesthetic gases comprise of 25%. That's a quarter of the NHS's carbon footprint. So me and my pharmacy colleagues nationally have co-founded an environmentally conscious group called Pharmacy Declares, focusing on how to tackle these emissions in our domain over the past few years. Before going through what Pharmacy Declares has achieved, I want to highlight this fabulous e-learning course I've undertaken called the School for Change Agents on the Future Learn platform. It describes old power versus new power, where in old power, people can make change happen because they have status and authority in their organization or system. So that could be your line manager, your executive board, budget holders. They can push commands through the formal system, and it's based on structures and processes that people must follow. And people are held to account through policies, quality standards we have to meet. A lot of people working in sustainability field, you'll find, is exercising what we called new power. It's this surge of energy that happens when people come together with a shared purpose. The more people that participate, the more power is created. New power is based on relationships. People engage in new power ways because they want to, and it fits with their own priorities and values, not because they must. The most capable leaders and change agents work with both kinds of power. If we want to make big change happen, we need to start thinking new power as well as old power ways, connecting with networks of people who want to contribute. So using the principles as change agents, Pharmacy Declare started lobbying UK pharmacy organizations to divest from fossil fuels and have surprisingly nationwide engagement all the way to the top levels. Turns out majority of the profession has been thinking about what they can do for the planet and wants to do more. And members in Pharmacy Declares have been invited to speak at many national and international conferences since, events, and provided input to national consultations regarding prescribing frameworks for clinicians, pharmacy education and training, as well as healthcare system operational changes. And we have people, like I said, listed on the slide to the highest level, asking us for advice and opinions on what they can do in terms of building a sustainable healthcare. Any of you in the audience are capable of setting up a similar group. You just have to be passionate enough and find the right people to build the future that you want to see and live in together. I'll now talk about some of the local projects our fantastic sustainability pharmacy team in Northeast England have been involved with. We've put together a proposal and won some money from the Greener NHS Healthier Futures Fund, working with a behavioural change organisation to run an inhalers awareness campaign widely across the region. The project focuses on asking patients to return inhalers into local community pharmacies for disposal, rather than discarding into bins at home that ends up in landfill. And when the canister crushes, it releases gases with global warming potential, causing climate change. It also encourages patients themselves to start a conversation with clinicians about reviewing and potentially changing to lower carbon inhalers should they wish to. This supplements the existing work done by our community colleagues in the lower carbons inhalers incentivized programs by the government, the Greener NHS. And if I can play this animation, if it allows. Ooh. No, it's not letting me play the animation. So an animation is what's been created by the behavioral change organization that will be publicly available in kind of, Instagram feeds, people's Facebook feeds, and there'll be posters running in local buses, swimming pools, just to get people thinking about their respiratory condition and what they can do in terms of helping the environment and better respiratory care. A lot of successes in the sustainability work streams are derived from behavior changes. And in order to deliver this campaign effectively, you have to know your local system very well and map out the key stakeholders across disciplines involving in policies that could be affected by this change. This can be really challenging due to differences in people's work priorities, background knowledge on sustainable healthcare, training, aims, and structures of their organization to implement the change. This is another project our pharmacy sustainability team worked on, introducing insulin pen recycling into all community pharmacies in a region. I believe this has now been rolled out by the pharmaceutical company Novo Nordisk nationally in the UK community pharmacies as part of their sustainability credentials. And again, there has been many meetings involving multiple key stakeholders across disciplines before this rollout of the recycling scheme. Working together on a huge project like this takes time and active networking. You really have to reach all the vital groups in order to make your campaign successful. Otherwise, it's just another short-term pilot that doesn't go anywhere, doesn't achieve anything. You really have to know your system and people very well. All hospitals in England now have what we call a green plan. This is an example of my hospital's green plan in relation to medicines and pharmacy. I've been in discussions about most of these with my hospital consultants, the estate team, my chief pharmacist, who are all 100% on board with the agenda. And don't be disheartened as well when you have doors shut on you. I've had so many doors closed on me when I approached the topic of sustainability initially a couple of years ago within my hospital. I faced so many barriers to implement change, but when people are ready to listen and engage, they'll know where to find you. This is a photo I took of a patient's weekly medicines tray on my ward that clearly shows they throw out these paracetamol tablets every week in the middle 2 slots. So that's lunchtime, tea time. That's about 1,500 paracetamol tablets in landfill every year. A lot of our daily jobs, such as reviewing polypharmacy, overprescribing, and deprescribing, are actually green activities. There's been a lot of focus on, plastic packaging recycling schemes from pharmaceutical companies. Whenever we mention sustainability in pharmacy, people automatically think waste management. But if you think we will stop these drugs that's not taken by patients in the first place, we don't even need to set up these blister pack recycling. We just stop the drug altogether. And that doesn't benefit the patient, doesn't benefit the planet. So I started reflecting on my consultation skills as a result. An example I like to use is almost encouraging patients to admit non-compliance. So for example, calcium chewable tablets is the one that patients complain that tastes like chalk, they don't like taking it. So instead of asking patients on my ward, do you take these for your osteoporosis management 1-2 a day? Oh, I almost start conversation with, oh, you're on these. Many people tell me that they don't taste nice, they're awful. And 9 times out of 10, I surprisingly found patients admit that or haven't taken them for months for that very reason. So then there's this shared decision-making process with the patient and going ahead saying, what about a different type of formulation? I guess a one when you swallow, you don't have to chew. That's more palatable. And then that improves their compliance, and it also empowers them almost to make the decision about their medications management. So we start to look at shared decision-making of evidence-based medicine beyond just looking at economic and social values, but also environmental value, this triple bottom line. One thing you can do this year is start raising awareness about pharmaceutical pollution in our water. We need to stop people washing drugs down the sink or flushing them down the toilets. There have been many published reports and research now about pharmaceuticals in our waterways, including antimicrobials. We know antimicrobial resistance is a global threat, and stopping drug pollution is fighting this threat. There's an intensive care consultant in the UK, Dr. Hickson, who co-founded Healthcare Ocean, and he designed these stickers on the slide to display in hospital sinks to advocate for oceanic health and marine life. So these wording I've highlighted. So I've sent some emails to our infection control team, our IT pharmacists, antimicrobial pharmacists, which resulted in this wording being included in every copy of TTO medications that get printed from our electronic prescribing system. And I know in the community, some general practices have started printing this wording in prescriptions pads also to raise awareness for the patients. Some of my amazing pharmacy colleagues have secured a grant from the Medical Research Council to develop what I call a green pharmacy formulary, looking at ecological impacts of every drug and for clinicians to take into account when they prescribe in the future. And these are some of the photos I took again on my ward. We know early review of intravenous to oral antimicrobial switch is already part of good antimicrobial stewardship. But have you thought about this through sustainability lens? Look at the plastic waste associated with giving drugs intravenously. It's also generating clinical waste, from giving sets, the diluents to mix the drug with, the cannula, the alcohol swabs. I have stopped so many IV paracetamol, IV morphine coming through accident and emergency onto my ward, and the patients clearly don't need to be on them. It also saves nursing time on the wards giving drugs IV to reconstitute them. This is an example of IV to oral switch of bioequivalent antimicrobial awareness poster done by some colleagues in Scotland. If you can review and stop that IV drug that doesn't extend any clinical benefit for the patients, just stop it. Another game changer for reducing polypharmacy and using nature as a health solution is social prescribing services offered in the UK. Healthcare workers and social workers in the UK can now prescribe gardening, prescribe running, swimming as part of patients' chronic disease management and improve mental health. Prescribing a patient, for example, with hypertension, heart run every week has the potential to lower their blood pressure. And maybe in the long run, they don't even need to be taking those antihypertensives anymore. And it might reduce their weight if they're obese, which then it reduces their overall cardiovascular disease risk, reduces the diabetes risk. This then reduces their need to access healthcare services in the future, which is a significant amount of carbon savings and cost savings as well. Conclude today's talk with 4 points to take away if you're new to this field or you're already in this field but not really sure what to do. Number one, don't work alone. Find your people, join them, build your sustainability network, attend all local sustainability meetings if you can. You never know who in that meeting might just be that powerful ally you need in the future. Number two, study your local systems. What's worked for us in the UK, for example, might not work in America. Get to know the people who can make things happen. Number three, design the improvement or change you want to see. If you don't know what your end goal is, then you're just going to waste a lot of your own time, other people's time in pointless meetings about pointless projects that doesn't go anywhere. Have that end goal in mind. Number four, measure the impact of your work and shout about it proudly. Share it widely so others don't need to reinvent the wheel and can be inspired to build a sustainable healthcare. And that is it for me. I will turn this to Dr. Alex.
Thank you so much, Mina. That was a fantastic talk. I'm just getting settled here. Really very inspiring work that you are doing and the NHS is doing, which I will speak to in my presentation as well. Really, the NHS and the pharmacists over there have been an inspiration for much of the work that we're trying to do with inhalers. And without further ado, again, my name is Alex Rabin. I'm a clinical assistant professor of medicine here at the University of Michigan and at the VA in Ann Arbor. Advances. I do just want to mention, that my views expressed here in this presentation do not necessarily reflect that of the United States Department of Veterans Affairs, of which I am an employee. And I also wanted to mention that I have no relevant financial disclosures, as I will be speaking about pharmaceutical products. I have no relationship to any of the companies discussed. So I started my medical training over a decade ago, if not longer now. And I remember first coming to my internal medicine clinic, encountering my first patient, which actually happened to be at a VA where I was training. And it was a patient with COPD. And I knew that the patient needed an inhaler for his chronic respiratory disease. I opened up the menu, and there we saw, of course, a long list of medications of various kinds. Now, I knew from medical school what the medications did, but I had really no idea how they worked or what the delivery devices were. And I went through 10 years of medical training afterwards in residency, fellowship, and then through attendinghood. And it wasn't until last year, despite the fact that I was deeply interested in climate and sustainability and had worked with Amy Collins at Healthcare Without Harm on advocacy efforts, I was embarrassed to realize that I was prescribing medications every single day in the pulmonary clinic here that could be having a detrimental effect on the environment. And it was really thanks to reading literature, largely out of the United Kingdom and Europe, that I came to realize, oh my gosh, we have a problem and actually, we can actually do something about it. So I went on basically a journey learning about this, and thanks to the work again that came before me, I was able to, put together a plan and start writing about this and raising awareness here in the US. So to back up for a second, for those of you who prescribe inhalers or fill these medications routinely, just a brief primer. So there are three main inhaler medication delivery device types. Probably the one you're most familiar with are metered dose inhalers. And of course, these are the common rescue inhalers that you'll see, as well as controller inhalers that contain a metal canister that contains typically a hydrofluoroalkane or a hydrofluorocarbon chemical inside of it that has the medication dissolved in it. When you depress the canister, the medication is released as the patient inhales. And this makes up about 70% of the US market as far as inhalers are sold right now at this time. Now, the other major delivery device that's out there is called a dry powder inhaler. And the reason I didn't show an image of them is because they actually come in lots of different shapes and sizes. Pretty much most inhalers that don't look like that typical metered dose inhaler puffer are of the dry powder variety. Now, these medications consist of a micronized drug blended with larger carrier particles. And these do not require a propellant. They don't require hydrofluorocarbon propellant. And they are basically just inhaled by the force of the patient's inspiratory effort. And then the last type of inhaler that's commonly out in the market is called a soft mist inhaler. And this is really a proprietary inhaler to one company, Boehringer Ingelheim, and it's called a Respimat device. And this is, again, a different type of inhaler that does not contain a pressurized gas. It has a spring-loaded mechanism that basically aerosolizes the gas that's then inhaled by the patient. So again, we have about 70% of our market here in the US that's metered dose inhalers that contains hydrofluorocarbons, and then the rest of the inhalers, or roughly speaking, do not. Now, hydrofluorocarbons, you probably heard that term at some point or another. Now, what are these? Basically, these are fluorocarbon gases that are commonly used right now primarily in refrigeration, in air conditioning units where they circulate, as well as some other uses. And these are very potent greenhouse gases ranging with heat trapping effect that ranges from thousands to several thousand-fold that of carbon dioxide. Now, about 5% of these hydrofluorocarbons are used in aerosols, and in aerosols we include metered dose inhalers. Now, there has been a global treaty that's now come into effect called the Kigali Amendment to the Montreal Protocol, which was the original protocol back from 1987, was an incredible global agreement to phase out CFCs, chlorofluorocarbons, which were the ones that were depleting the ozone layer. Now, since the agreement, the U.S. has actually now ratified the Kigali Amendment to now get rid of hydrofluorocarbons because of their effect on global warming. But there are actually carve-outs for several uses, and one of the carve-outs in the law is for metered dose inhalers. Again, just to review, we have sort of this series of gases that have been used in metered dose inhalers. Now, the old school gases that were used were these CFCs, CFC gases that were used in your traditional albuterol inhalers, and these were phased out with some difficulty in the US as a result of the Montreal Protocol. And when I say difficulties, because they were replaced with much more expensive, frequently gases, inhalers that were replaced by inhalers that were put back on patent. The current propellants that are used are these HFC 134A and HFC 227A, which is happens to be the primary propellant that's used in Symbicort, and I'll say why that's important in a moment. And then there are some future propellants that are currently under testing that have much lower global warming potential, but which are not likely to be available within the next few years as a result of the FDA's stringent testing requirements and study requirements. Advance the slide here, sorry. Okay. So one of the big problems in the US currently with changing wholesale away from meter dose inhalers to the non-propellant inhalers, which is what the UK and what Mina spoke to has done, is doing and is working on so effectively, is that right now we do not have approved non-MDI inhalers for what the international GINA guidelines would recommend for asthma management. In fact, despite the fact that the majority of the trials for asthma treatment were conducted in dry powder inhalers, there is actually no approved dry powder inhaler that can be used for mild or moderate or even severe asthma with a combination ICS LABA. And that creates major insurance headaches for any of those of you who have tried to prescribe, for example, a budesonide formoterol inhaler like Symbicort for a patient. It creates a big problem. So we can't actually, in the US currently, with ease, follow these international guidelines for asthma therapy. So there's really an opportunity here to pressure regulators and the government and pharmaceutical companies to try to do better. We know that worse asthma control means higher greenhouse gas emissions, and we know that from several studies, including the Sabina trial over from the primarily from the UK, which shows that patients who use a lot of short-acting beta agonists, for example, like albuterol, which primarily come, actually in the US, they've really almost exclusively come as pressurized meter dose inhalers. The more of those albuterol inhalers you use, in fact, greater than or equal to 3 inhalers a year, which is actually a lot of short-acting beta agonists, those patients also contribute a lot more to greenhouse gas emissions. And again, it's mostly driven, we think, by excess use of these meter dose inhalers. Now, there are studies, again, coming from the UK that have suggested that switching from a meter dose inhaler to a dry powder inhaler for a LABA ICS, a long-acting beta agonist inhaled corticosteroid maintenance, is good both for the climate and for asthma control. And in fact, this analysis actually a post hoc analysis of a trial that was funded by AstraZeneca showed that basically by switching patients to a dry powder form of a controller inhaler, you could not only reduce the amount of total rescue medications used, you also reduce the CO2 equivalents. And most importantly, you also maintain control as measured by the asthma control test, ACT. You maintain asthma control just as well, if not better, with a dry powder inhaler. So there is really a lot of motivation. There's a lot of reasons for why we should be trying to transition patients when possible away from pressurized meter dose inhalers that contain HFC gases to dry powder formulations when we can, while still maintaining good asthma control. Again, in the UK and in Europe, there are really forward-thinking regulations that are slowly going to fully phase out these F gases from clinical practice, because they know that the alternatives work for the majority of patients. In the US, again, we have a planned phase down for these gases, but at the moment, medical inhalers carry an exemption. And so we've tried to raise awareness, myself and some colleagues have tried to raise awareness about these issues, which for, I would dare say, for most pulmonary doctors and GPs and primary care physicians in the US, this is really an invisible issue. As I was polling my own colleagues here in Michigan and back in Boston, where I previously worked, there was really, I would get a blank stare when I would mention the inhaler greenhouse gas emissions that we are contributing and putting out in the atmosphere. And so we've done a little bit of writing, and we wrote a piece in the New York Times to address this, again, building upon the work of many others who've come before us. My current focus in research, and which is very exciting to me, is we've proposed a couple of projects to actually look more specifically at the inhalers that are here in the US market and to perform life cycle assessments to better understand exactly what's going on with the clinical effectiveness as you switch patients from US formulations of MDIs to US formulations of DPIs. And unfortunately, that information is pretty hard to come by. Now, we think we know the answer, of course, based on UK and other countries, but we don't actually know for sure because there's very little research that has been conducted on this in the US. And so I hope to come back to you guys at some point with some actual hard research that's coming from our own patient populations. And with that, I want to thank you so much for your attention as we try to breeze through this issue. And I will be turning it over to Dr. Blackburn from Montana.
All right. Thank you so much. Thanks to both of my panelists. I'm really happy to be here. I'm excited to talk to you a little bit more and build upon these great presentations that have happened already. So they've set the stage. We're familiar with the big picture of healthcare's carbon footprint. We've seen some excellent specific examples from the NHS and a really great deep dive just now into the world of greenhouse gases and inhalers. And so now my goal here is to give you a general global overview of the carbon footprint of pharmaceuticals, some of the current issues, and hopefully some ideas for actionable opportunities to promote climate smart pharmaceutical use that can be adapted and applied across multiple settings. So it's gonna be a whirlwind tour. Hang on, here we go. Let me make sure that I can navigate the slides. All right. So we can see here some specific examples of the estimated relative contributions of emissions associated with pharmaceutical products as a percentage of the total national healthcare carbon footprint of some of our top emitters. And most data show that pharmaceutical products account for anywhere between 20 to 30% of healthcare sector emissions. And a study published in 2019 also compared the Scope 1 and Scope 2 emissions of the top pharmaceutical industry manufacturers with that of the auto manufacturing industry and found that it was 55% more emissions intensive in the pharmaceutical industry, which may seem really surprising. I know that that is kind of a potentially shocking statistic. So I think it would be helpful maybe if we dig into the general life cycle of pharmaceuticals a little bit more. It's easy in our day-to-day as clinicians, health professionals on the front lines of patient care to really forget about all of the steps that might go into the creation, manufacture, distribution of that product before we're seeing it ultimately administered to the patient. So we'll look at this high-level depiction here of the basic steps in our pharmaceutical life cycle. So we have first the production of the active pharmaceutical ingredient, that basic component of the drug that then goes on, gets a secondary step where it's put into some formulation, mixed, packaged together into a final form, gets shipped to a wholesale distributor. That's our centralized storing place where we then look at distribution around the world. Finally, that drug shows up in the hospital pharmacy facility where it is ultimately then dispensed and administered to the patient. So kind of a lot of details and considerations along the way in this process can be kind of complicated, but really even this is an incomplete picture of the accounting of what's going into our pharmaceuticals. So that past slide there didn't include some of the inputs into research and development that goes into bringing a drug into the market, something that isn't always well quantified, and it's very energy and materials intensive, takes us from initial drug design all the way through clinical trials. We also excluded the other end of this life cycle. So the patient travel to and from the pharmacy or whatever transportation is needed to get the drug into the patient's hands. And it didn't account for medication waste, the transport, the disposal of unused medications, the incineration that might go into that, or the fact that our supply chain doesn't just move in one direction. It goes in both ways when we have to send back expired medications, recalled medications, do drug takebacks, all of those things. So a lot of steps, again, certainly things that I haven't fully captured here, full disclaimer, but we can look a little bit more closely at some of the pieces here maybe that I think give us maybe major contributions, but also major opportunities to intervene. So we'll start upstream in this first half of the process, the steps from the R&D to the wholesale distribution. So research and development, a lot of waste. We know that this isn't an investment that ends up with one-to-one investment that ends up with a finished drug product approved and on the market, helping patients in our day-to-day clinical practice. It's very resource intensive, energy intensive, and for a long time has not really been considered any type of sustainability considerations built into the processes there. And so this is a movement that's changing now. There's a lot more green chemistry. There's a lot more effort being put into the design of drug products and the ways that they're made that will promote sustainability in the pharmaceutical industry. Pledges being made, and a lot of exciting movement in this area right now. For the drugs that have been on the market for a long time are generic medications. However, there may or may not be those sustainability pledges in place. We know that somewhere around 80% of all of our generic drugs are manufactured initially in China or in India, and then they're shipped all over the world. It's a very convoluted, fragmented, and inefficient process. One facility will manufacture an active pharmaceutical ingredient, that pure, raw, synthetic compound. We know that's a really, really intensive and both energy and materials intensive process in our chemical industry. And then that gets shipped to a secondary production facility, gets turned into its finished product. Ultimately, that tablet, capsule, ointment solution, there might be another step where it gets packaged at a separate facility, back and forth, very complicated, ultimately before it ends up in the wholesale distributor hands to go on to the place that we ultimately need the drug. There's been conversations about this in the context of drug shortages and quality concerns, where we're seeing drug recalls, getting more attention from the media, from regulators, from lawmakers. And these are really serious and urgent issues because we're seeing things like shortages of critical drugs like amoxicillin that we can't keep on the shelves consistently, that's impacting patient care. But this is also an opportunity for us as we're looking at our supply chain and securing our drug supply to think about sustainability simultaneously. We also know that wholesale distributors, being the centralized place to receive and ship drugs all around the world, they're really a key player here. They have their role to play in decarbonization, and many of them have made some sort of decarbonization pledge, but managing their inventory efficiently, looking at their supply chain, their shipping strategies, decarbonizing their fleets, all of those things are going to have a big impact down the line. This ultimately is even this is my attempt at maybe a very cute and oversimplified version of what the pharmaceutical supply chain looks like on this end. And even that mess of arrows there is probably a way oversimplification. So for many of you, you might feel a bit removed from that upstream process of the pharmaceutical supply chain. So let's talk about some of these later processes. In general, I think we're all aware that there's a large amount of pharmaceutical waste generated through our operations, multiple points along the way. And this waste is really kind of a wicked problem. We don't have any one individual player that we can point fingers at. We know it's a system structure that really drives much of it. And many of us want to make changes, and it's just difficult to do so. At the pharmacy or hospital level, a lot of times inventory management practices, policies around pharmaceutical use can contribute to pharmaceutical waste. So like we've seen those instances where we have a multi-dose vial or a half-used insulin pen or something that's discarded with perfectly good medication in it just because there's some policy in place that prohibited more efficient use processes. We can also see things like overstocking of inventory that leads to medications expiring. We have to ship them back or dispose of them, with plenty of evidence out there that actually those medications maintain their efficacy and safety long past the expiration dates that are on those bottles. So something that we should be scrutinizing at a higher regulatory level or a labeling level down the line. We also see issues at the level of prescribing and dispensing. Of course, we know polypharmacy, the overuse and inappropriate prescribing of medications that we know already leads to poor patient outcomes. Dispensing practices that lead to a lot of waste and for increasing pharmaceutical costs. And we know that deprescribing is really, really hard to do for a number of different reasons. Again, it's the system, this lack of clear guidance on how to approach that, uncertain priorities, not great communication all the time between systems with different EHRs and facilities and so on. We also know that in the patient side, patient adherent rates are notoriously low. So the World Health Organization estimates as low as 50%. And there are a lot of different patient-specific factors that are going to play into this, whether that's adverse effects that make them discontinue the medication early. Maybe they didn't receive enough education up front. Maybe they're stockpiling it due to affordability issues. Medications are expiring before they actually get used. All of this waste ultimately ends up at the end here of the pharmaceutical life cycle with one of several options where we're throwing it in the trash, we're giving it to a drug take-back facility, we're flushing it down the toilet, or we're sending it off to some place to incinerate it. And all of this has impacts in terms of greenhouse gas emissions, whether it's from the transportation, from the incineration process. For all of this can be truly difficult to quantify how much waste is in our system. But obviously, this is one of the worst things we can be doing in our efforts for decarbonization. So to get at the idea of the waste reduction circularity concepts as it applies to pharmaceutical use, I'm going to propose this R model or R framework, which is our framework that we use in conversations about sustainability or circular economy with all of our R words here. So the first step, refuse or reduce. When we think about using our pharmaceuticals in our prescribing decisions and utilization. So obviously, foregoing unnecessary drugs is step one. That includes the initial prescription, but that should also include our considerations of prescriptions that we refill indefinitely. Maybe we don't always give that a whole lot of thought or scrutiny because that patient has been on a drug for a really long time. We know that deprescribing is really hard for many reasons, but I think that does give us some greater urgency to invest in systems and people who can help do that effectively. We can also minimize packaging waste, flow rates on anesthetic gases that can help be part of that refuse and reduce component there. Then there's rethink. How do we make better choices about the use of the product with the right data? We can rethink the way that we evaluate our options. We can choose the lower carbon option. And this is going to require more guidance for us, decision support tools, systems in our electronic health records to really be able to do that effectively at a large scale. And we're going to need the research and the transparency upstream to be able to make those choices. We can think about the way we order, package, dispense drugs. Maybe we want to think about a smaller quantity on that first fill when we're not sure if the medication is going to work for that patient, or maybe we need to scrutinize that PRN order that comes where we normally give 30 tablets out. Maybe that patient only needs 3. Maybe we should look at that a little bit more closely. Minna pointed out a great protocol with the IV drip versus the oral options and how we can rethink our processes there to reduce waste. Reuse and recycle, Minna also gave great options there for how that might look. We can also think about what do we do with those medications that are still good that maybe could be returned to the pharmacy? They're still have good quality, good purity, safety. Can we redistribute them somehow? Can we get them hooked up to medication donation programs so that those medications don't just go completely wasted? And as we're seeing more and more devices on the market, thinking about how those devices should be designed and like preferentially chosen to be recyclable or reusable rather than that insulin pen that's a one and done, not possible to recycle and entirely wasted. And then finally, better removal processes. So good disposal practices, making sure we're making the right choices around which drugs need to be disposed of, and then making the right choices about how they should be disposed. So if we can do all of those things effectively, we've done a lot to reduce our overall waste here. And both of my fellow panelists already touched on this, so I won't go into great detail. I already mentioned this. But I think it is worth underscoring that the lowest carbon medication is no medication at all, and keeping people healthy is one of our longest levers here. So we're already thinking about these things from the standpoint of patient outcomes, reducing healthcare costs, and the added benefits of decarbonization in these efforts can give us extra incentive, maybe help give us more urgency on these efforts. These are all linked together, they're not at odds. And so if we move the needle on one, we can move the needle on all of them. Some stakeholder opportunities here. So there's opportunity to promote decarbonization of the pharmaceutical sector, kind of regardless of where you are in the way you interface with the system. So as I discussed earlier, there are many ways that pharmaceutical companies can set themselves up from day one to consider circularity concepts and make it easier for us to then make sustainable decisions down the line. So that drug at the very beginning is designed to be sustainable, and at the end is designed to be benign. Distributors and purchasers can look at their supply chains, look at decarbonization from that standpoint, and they can be transparent and hold all parties accountable in achieving decarbonization goals. Insurers and policymakers can put in systems that preferentially pay for lower carbon pharmaceuticals, making those lower carbon pharmaceuticals most appealing for us. And then for us, facility administrators, healthcare professionals, patients, all of us, we have this collective purchasing power. We have this collective voice. We have this decision to, start being champions in this area and thinking about those suggestions that I made earlier. Also, well-informed patients can be a powerful voice. So thinking about them as our allies in this process. And I'll make a quick promotion here of pharmacists for their making us give the right amount of care. So we're very, very good at both increasing access, improving health outcomes early on, and reducing unnecessary waste, unnecessary admissions, everything. So pharmacists, this is a call to action to you. Non-pharmacists, please ally with us. We can be really powerful agents in helping with these decarbonization efforts. My slide, there we go. Okay, so stewardship of medication, rational use of medications. This isn't a new idea for us. We're worried about stewardship of resources, optimizing patient care, thinking about the collective. And so as we go forward, this isn't something that's foreign to us. It's something that we just need to layer in our considerations of ultimately, what are we doing with the environment? Mina mentioned water pollution, land use, impact on ecosystems, and health equity. It's not just about the carbon emissions overall when we're thinking about pharmaceutical stewardship. And I really loved this redefinition here of rational use. So this is the World Health Organization that just added, consider the interconnection between people, animals, plants, and their shared environment when we're defining rational use of our pharmaceuticals. So these are my final thoughts. Gaps and needs and benefits and opportunities. I think that if we can focus on some of those co-benefits, really think about the positives that can come as we link patient outcomes, safety, climate resilience to our efforts in decarbonization, we can really, really move things forward and gain some momentum. And then I'll put in a last minute plug here for any pharmacists or others out there interested in connecting around these issues. rxforclimate.org is our organization that is a web-based community, international community of pharmacists and others interested in these issues, looking to connect, collaborate, advocate, and educate. So thank you all so much.
Thank you so much, Haley, Alex, and Mina. What an incredible amount of information, and you guys are amazing. We have a ton of questions from our audience. So we'll start with the first one here. This question is for Alex. So with CMS in the US now kind of on board with the climate crisis, can they work with the FDA to approve dry or reduced propellant-based inhalers?
Thank you. Very, very good question. I will caveat it with the fact that I am not a regulatory expert, but what I can say is that like inhalers, like every other medication in the US, are just we are faced with a very, very complex economic and incentive program here that makes it such that for example, if we wanted a Symbicort dry powder inhaler, so the type of inhaler that is now recommended now for mild asthma, at the current time, the drug company that makes that inhaler has really no economic incentive to move it forward into the US market. And it all has to do with money, because they would have to rerun huge trials, multi-million-dollar, if not billion-dollar trials, in order to get those drugs approved. Because that drug is now off patent, they have really no incentive to do that. And that's based on conversations I've had and my colleagues have had with the companies themselves. So yes, I think right now there is, I know there's a congressional inquiry going on to try to better understand how we can move some of these inhalers forward that we know work in other countries, yet we don't have in the US. Is there a way that we could fast track those, for example, those approvals to make them more widely available to meet our both health and climate goals? I think that's a major issue and one that I think is going to require a lot of advocacy.
Gotcha. Thank you so much, Alex. This is a question sort of for all of you. So the question is, how can pharmacists and clinicians or prescribers really work together in this space? How do we amplify sort of knowledge we have, and how can we work together?
I think the thing that I would say is that we're already looking at new projects, new initiatives to improve patient outcomes, to reduce healthcare costs, and we're not always tracking or thinking about in those efforts how we're also decarbonizing, and those things, theoretically should all be linked and run in line. And so as we're doing these things, as we're tracking outcomes, doing quality improvement initiatives, can we layer in that consideration of decarbonization and make sure that it's not impacting patient care outcomes, it's not somehow also negatively impacting costs. And then I think that integrates it more into our conversation and makes it that thing that we're looking at. Is it effective? Is it safe? And then what is its carbon footprint overall?
Yeah, fantastic. Mina, did you have something to add to that?
I would just say collaboration is quite key. So reach out to any clinicians possible. So when we started pharmaceuticals, we were basing a lot of our models and work already done by our medical colleagues and nursing colleagues. And slowly along the way, we helped the physio set up physiotherapy declares. So then you start building your network. You kind of know what everyone is up to, and then you might be able to join in some of the projects. For example, if their project touched briefly on medicines, then pharmacy can be involved. If my project touched briefly on speech and language therapists and needing swallowing assessment, then I can get them involved. So I think get actively networking in this area. People will be interested in the subject matter if it relates to their profession as well, and trying to give their expertise and guidance, rather you going blindly and trying to create something that's already known or like there's guidelines for.
Mm-hmm. Yeah, great points. And Alex, any thoughts on how you've seen sort of effective collaboration with pharmacy colleagues in this space?
Yeah, I think that, pharmacists, at least where I practice, are now empowered to really guide therapy for conditions like congestive heart failure, among other chronic diabetes, among other chronic conditions. So I do think that actually clinical pharmacists should be empowered and are in some cases to make decisions that can take these issues into account. So I think Yeah, I don't have a specific prescription, but I think it is happening with certain diseases. In my field, in pulmonary medicine, I think we're still behind. So I think there are more opportunities to try to empower pharmacists.
Yeah, thank you. All of you really brought up some incredible, I would say just low-hanging fruit in terms of things that we can start changing tomorrow. You know, we have enough evidence now that we can act, right? We don't know everything, but we do know enough to act. And so my question is, you know, how do we take these learnings and these messages and amplify them on a larger level? So for example, is there any education about this in, you know, in medical schools and nursing schools and pharmacy schools? That's my first question. And two, is there opportunity for, you know, continuing health professional education in this space? And have you seen any effective examples of those?
I can speak to the pharmacy profession. So I think that is something that we are really working on right now to try to integrate it more into pharmacy curriculum and into our discussions and training for incoming pharmacists, and try to make CE opportunities more available. I think that it's really encouraging to see how much more is available out there, but it is not yet a core part of our curriculum in pharmacy when we're looking at drug product selection and how we navigate those choices. So I think there's international and national efforts within our group and outside, looking to try to advocate to make that a core part of our training requirements and make it a greater conversation within the pharmacy profession.
Yeah, and I would echo among medical trainees, I think too, there's currently a wave of interest across medical schools. At our own medical school, as well as many others, through organizations like Medical Students for a Sustainable Future, that are pushing to integrate sustainable practices and the importance of climate change in education across the country here. And I think this is just yet another opportunity. I responded to one of the Q&As, which I thought was really a good idea, which is to incorporate this into, for example, pharmacology education in the first year medical school. For a lot of these topics are not really rocket science. It doesn't take you don't have to have an advanced degree to understand that hydrofluorocarbons contribute to climate change. So it doesn't take more than a slide or two. But even that little bit of attention, I think, can hopefully plant the seed in our students and drive change in the future.
Mm-hmm. Thinking about, you know, what you were sort of saying about new power and old power. How do we leverage our power as health professionals to influence, you know, these forces above us, you know, like supply chains and the decisions made there? How can we sort of partner with, you know, for example, distributors and manufacturers, or put pressure on them in different ways? How have you seen that be effective? And I know the NHS is pretty far ahead on this.
Collectively is the answer to that. So I'm not just saying about pharmacists and pharmacists collectively, so pharmacists and doctors collectively, and nurses, all allied healthcare professionals. If you speak together in a coordinated one voice, asking pharmaceutical companies for the same thing, instead of waiting kind of from your top-down actions, you start bottom-up, you start lobbying, you start making noises, you start writing letters, emails to pharmaceutical companies, demanding carbon footprint information, transparency in your data, your supply chain, where are you sourcing your active pharmaceutical ingredients from? And a part of this is implementing policies and legislation as well. I agree, and our NHS has done a great job implementing kind of net zero in healthcare legislations and policies to incentivize kind of lower carbon inhaler schemes. And they have made the supply chain in the next few years in order to deal to have business within the healthcare system. 10% of your tendering process is weighted on environmental value of the company. Yeah, can you provide scope 1, 2, and 3 emission data before we trade with you? If not, we're ceasing trading with you. That's just that simple. And I think carbon literacy, I think beyond carbon literacy as well, ecological impact, you know, it's not just carbon. There's something called carbon tunnel syndrome. So we talk a lot about carbon, but that is the easiest way people can understand that in terms of that at present. So education widely is still required, I find. And a lot of people, I mean, people in this audience that seem quite clued up with the agenda, but there's so many people we work with in healthcare systems that's unaware of the climate emergency. So seek to bring people on board. And, you know, there might be, it's quite a politically charged subject as well. Don't shut out people who refuse to engage with the agenda. Try and bring them on board slowly and make them understand the science, the data. Like we said, the data is all out there. We just need to bring them on board to their level of understanding and what are their values, and attune to that and communicate that way.
Thank you so much. We are at the top of the hour. We have dozens of unanswered questions. I mean, just speaking to this is such a rich topic, and it's really, really inspiring to see how much possibility and potential there is for change. So I'm going to turn it over to Shanda, who's going to talk about how we can continue these conversations at CleanMed.
Terrific. Thank you, Cece. Thank you to all of our speakers today. I've dropped 2 links in the chat, everyone. We have events coming up in person and virtually in the US in May at CleanMed. We also have a CleanMed Europe this year, as well as a few destination CleanMed events that are free and virtual to access. So if you want to continue this conversation, we have a session coming up about inhalers and diving even deeper into that, plus dozens of other sessions that we'd love for you to join us in. So again, what a pleasure to have you all. Cece, do you want to close us out?
Yeah, thank you to everyone. And we'll be back with you with another session in our series this May. So stay tuned and everyone have a great day.